Hello, I'm Patty Thorpe in Phoenix, Arizona, and it is my pleasure to participate in this digital education series. And I want to thank Dr. Walker and all of his staff for helping me with this endeavor. And I'm very happy to be part of this series and help teach some more in this new era of teaching with the internet, which is different for all of us, and we all miss the conferences, I'm sure. So I'm going to go ahead and talk about the ways that I do totally occluded iliac vein recanalization. And there's a limited amount of time. Here are my disclosures. I am a venous consultant for several companies. And the whole thing about iliac vein crossing when it's chronically occluded is actually almost seems like a miracle every time you do it. And I want you to think of the movie The Italian Job whenever you come to do one of these cases that are very challenging. Sometimes when it looks really hard, actually the wire will go right through and you can't believe it. And sometimes it looks like this should be good, and it takes you a couple of days to get where you want to go. And I'm not kidding. It can, in fact, take more than one day, because if it's an iliac vein that's been occluded for years, how do you expect it to just open up just because you decided that you want to do it? So we have to remember that there are many elements in terms of how these people got thrombosed and came to you after many years of recurrent DVT in some cases. So if you haven't seen The Italian Job, I encourage you to see it because there are many similarities and parallels. Now, crossing a chronically thrombosed iliac vein looks like it's difficult. In the beginning, when you first see a venogram like this, you think, where do you start? But after you've seen hundreds of venograms like this, you know that there's similarities in every single one because the body can only do so much. It can only have cross pelvic collaterals like this. It can have iliolumbar collaterals like this, have collaterals around the common femoral area like this that go over to the other side, almost like a natural bypass. And then it always fills over to the opposite side. And of course, this patient is prone, so this is the left side. So my tip number one is that crossing a chronically thrombosed iliac vein is like picking a lock. I've always thought that the intelligence is in your fingers, not so much in your eyes. But you do have to watch carefully because you teach yourself where you know the vein should be. But it's the feeling in your fingertips when you're moving the wire that gets you through the old clot. You must be patient. This takes time and finesse. You have to think patiently and combine that with your skills as you get better and the cooperation of your team that is patient with you, because it's sort of a single person thing. Once it gets this difficult and you're up through the middle of the iliac vein, it's not something where I let a first-year resident on their second week of doing things kind of help out, because it's kind of treacherous if you put a wire through the vein at that point or you go into the wrong way. And we all have done that, but you have to be very careful not to go into the spinal veins or make perforations in the area where you're in near the bifurcation. And above all, you have to believe it's possible. And I think that's why a lot of people bail out of venous work, to tell you the truth, because I think they see this complexity and they're not that familiar with the anatomy. And it just doesn't seem possible to them. So it's too much of a challenge. Okay, we'll move on. Tip number 2 for me in dealing with these chronic iliac occlusions, and this is actually the same patient, a different view, and you can see the chronic thrombus here, and this is where it should be going, but you don't see this part yet, which is where the iliac compression is. But the tip number 2 is that catheter-directed TPA actually softens up this old thrombus. It doesn't dissolve it all. It just actually makes the channel so that you can work with it and you can get devices through like an IBIS catheter, like a sheath delivery system for a stent. If you try right now to stent that vessel, first of all, you can't even get an 035 wire up there yet. And second of all, a 5 French catheter goes rather in a difficult manner. And thirdly, there's no way that you're going to be able to get a big sheath up there and deliver a big stent until you soften up the internal canal. And then you do the requisite angioplasty to open up this vessel. And you cannot do that on day one most of the time. So you have to be prepared for staging these events. And so you need to be able to use your 035 wires. The Roadrunner is my best wire, but an angle glide wire works really well. Some of the V18 wires work. And then on day 2 and day 3, you might do angioplasty and continue to prepare for the time when you're going to actually deploy your stents. And before you get to that point, given it's a hard case and it's very chronic, you plan for what size you're going to use and you make sure they're all in the lab. And it's not something that you do the first day with a case like this. Sorry. So you can see in the same patient, who was a young woman who came from Canada to have her leg fixed when everyone there told her it was impossible to get chronic DVT treated. You can see the old thrombus. And this is after a day of thrombolysis, 24 hours, sure, because you see the pattern around this common femoral area has changed. And you're not seeing so many collaterals at this point. You're seeing some flow, and it's going this way and it's going this way. So it's actually opened up a little bit in terms of a better collateral compensation, but we're still interested in going north here. So this is what you're dealing with, and I would, in this other case, I'd be bring my sheath up from a popliteal approach to this point, to the common femoral. There we go. And then start putting a Roadrunner, floppy tip Roadrunner up to the top. Now, this is the actual May Thurner, which you could not see the day one because it wasn't visible. All the thrombus was here and there was no contrast going in this area. And you can see that when you get to the common iliac vein, there are generally 2 channels at least, minimum of 2. Sometimes there's just one choice, but most often there's more than one choice. This happens to be the lateral channel. This happens to go medially. I have found over the years that it's best to take the lateral channel, which would be here. See, it's deceptive. You have to watch where they go. And go up and get your wire and anchored here in the cava so that when you put in your stent, excuse me, it'll actually be pointing north and you'll have the best trajectory. Clearly, when it comes up here and you release, it goes over towards the other side. But I like to go up on the lateral aspect so that I have my stent pointing north towards the heart. And then it gives a room for the right side to be open. And here is the placement of her stents. These are not really large stents. They don't need to be really large stents in a small woman. This lady weighed about 115 pounds. She was a little person, but she's very active and very athletic. And these stents are perfect for her size. And we actually usually always measure from the opposite side where there's no disease and get an idea of what her normal vein would be. So in her case, a 14 millimeter stent is an appropriate size for her, or a 12 millimeter, depending on what the veins are like down below. I like to size them so that they're appropriate. And for those of you who think the bigger is better in terms of stenting, it's actually the best way to do it is to size it to the patient's natural vein capacity, because then the body will correct the flow pattern better. If you put in too large of a stent, the body has a tendency to narrow that stent with buildup so that it becomes more like the size it was originally. So too big of a stent is not a good idea. And of course, I don't use anything smaller than 14s most of the time, occasionally a 12. So tip number 4 is that if you're going to do iliac stenting, you must understand the anatomy of the person and the inflow capacity before you start this case, because you have to pick your right approach. And that's why your ultrasound tech is so important in giving you the information that you need to plan these cases. It's clear that you can get the information in different ways, that someone has a chronic occlusion, a chronic post-thrombotic syndrome, etc. But you really need the information that the tech can give you to show you where you're going to come from. You can't just come in the femoral vein on all of these cases. It's very important to know that there's disease in this area so that you come in from below that, because this has to be treated and improved upon so the flow from the deep system is better. Otherwise, eventually, this may clot off. They may or may not develop a large profunda collateralization. And then you jeopardize your stent patency. The best stent patency is when you have good outflow and good deep vein inflow. You can never depend on a great saphenous vein for inflow. You have to correct this area. So if you think you're dealing with a chronic iliac occlusion and you decide, oh, I'm going to come in the upper thigh, come right here, you're going to be coming into a minefield. And you may be able to deploy some stents, but never low enough. And you're going to end up doing an insufficient job, and they could thrombose rather quickly because they don't have very good inflow, because you came right into the middle of the problem. Now, this is an example of the same patient. You see, if you do a venogram from below, and in many of these cases that have chronic DVT, I do a pedal intercath, and I do an injection from below. So this is the calf over here on the right. This is the tibial area going just up to the knee on this image. You can see that she's got evidence of old DVT, but it gets worse when it gets up into the femoral part. Her saphenous is taken over to this collateral as transpubic. And of course, here's their femoral coming up, and it doesn't look as good on IBIS as it does on the venogram because there's a lot of residual thrombus on the side, on the wall. So it's important to learn how to use a popliteal approach when you're doing iliac obstruction cases, because you need to come from below. I've done a number of cases from the contralateral, which is almost impossible when the iliac is occluded chronically. And the IJ approach is very difficult to get down, not impossible. Depends on the patient, of course, but the most successful, consistently successful approach is the popliteal. And the trick to the popliteal is the stay-fix device like this that you can buy in a box of 10. And it's designed for catheters like nephrostomy catheters, but actually it's perfect for thrombolytic catheters and sheaths. And when you make a single wall puncture and you have, in this case, an 8 French sheath, and you're running TPA, you have a good seal, and you can see up close that the stay-fix is designed to secure the side port, secure the side port of the sheath, as well as the catheter, which seems to be removed here. But then you're padded, and you have your tegaderm, and then you wrap your leg in Curlex, then Coban, and the patient's very comfortable when they're on the ward for the TPA infusion. And I want to give you another hint about taking out the sheath. Many times physicians have called me and said, God, we got a great result. got rid of all the clot, and we took the sheath out and rethrombosed. And that's probably because there was thrombus in the popliteal region here, or it wasn't adequately anticoagulated during the procedure, so that clot did build up around this sheath. This happens to be an upgraded 10 French sheath now. But you can pull that sheath with a patient having an INR of 3, PTT of 50. They're anticoagulated enough not to thrombose. And all you want to do is hold pressure for about 10 to 15 minutes with the patient on there in the prone position. And then you wrap the leg with the kind of pressure dressing that I show. And the patient doesn't get up and walk for 12 hours. I don't let them go to the bathroom. I let them use the bedpans or urinals. And I keep people from putting weight on that leg as long as possible to avoid any hematoma. And the reason why I know people get hematomas is because in the early days, I wasn't as strict as I am now, and patients would try to sneak to the bathroom, and then they'd be very sorry that they got a big hematoma behind their knee. And that's one of the worst complications, because you can get a foot drop from that if you bleed into that cavity and affect the nerves. So I avoid that at all costs. And a few hours is not going to be a high price to pay for having your leg be good for years after that. I want to share with you that IBIS, I believe, is a great tool for venous, a great teacher for us, so we can see what's going on the inside of these veins, as well as the inside of these stents. And I have done this for a long time, and I've watched thrombus that is day 1, day 2, day 3, day 4, and I've seen it change. So it may be that a lot of the old organization of thrombus that's been there for years becomes more like collagen, but it's a dynamic process, so that there's clot, new clot sometimes forming in the midst of old organized clots. So you have always a rainbow of different ages of thrombus, some of which is very amenable to resolution with TPA. So you can increase the size of your lumen with TPA. And that's a very good idea, because the bigger you can get the lumen, the wider your stent will deploy and the better result the patient will have long term. So those are a few hints and tips about doing iliac repair. And I'm going to show you a case of one of the hardest things you can encounter is a totally occluded iliac stent. And it's going to, utilize some of the principles I've just shared with you when we started just seeing some cases. Now, this is a young man who was unfortunately wounded when he was only 23, and he had an embolization of the bleeding arteries and a patch of his left external iliac vein. And he stopped taking his anticoagulation in 2017, and that left him with a hypercoagulable situation where he ended up occluding his stent. So he sought help from us to revise this occluded stent. You can see his left leg is quite discolored. He has dependent discoloration and swelling of his ankle, and he was very symptomatic. He's a young person. He likes to be mobile. He pushes himself a lot, but this leg was really bothering him enough to come in. And you can see collaterals that were forming in his groin area. So this is a telltale sign or pathognomonic for total iliac occlusion. Now, one of those principles is that you have to pay attention to the anatomy below the problem. And our ultrasound showed us that he had chronic thrombus in his femoral vein. Popliteal was okay. So the femoral vein has been duplicated, and you can see that the medial channel is pretty rethrombosed. And so we're trying to open this up, and we can use gentle angioplasty with a 7 or 8 millimeter balloon in this vein and get it to be better. You see, as you get higher and get closer to the iliac, you run into a lot of old thrombus that is probably a mixture of acute, subacute, and chronic. And one of the things that helped get through this area, besides just using a glide cath or Rubicon or any of the Navistar that we have, is a new kind of catheter that I'm going to show you called a Zabel cath. Zabel stands for crossover cath, and it's designed to go through more firmly organized thrombus in both arteries and veins. So this is a pretty nasty picture of a lot of transpelvic collaterals, a totally occluded nitinol stent, which is mangled here at the inguinal ligament, and up above you can see the coils, you can see the bullet fragment that's still there. And this is a Zabel crossing catheter that has a blunt tip that's metal and a more serrated tip that you can twist with the twisting mechanism to try to cut through very organized thrombus. This is a 5 French catheter. It takes an 018 wire, and then you can change to an 035 wire, which I think is very clever. And the best part is it's braided here, so it gives you a lot of ability to push forward without buckling. And that's one of the main problems with most of our catheters, is that you can't track them very well, because when they come up against something very hard, they buckle back and can kink pretty badly. So you see, with this combination of the Zabel cath, which has a metal tip, and this is a V18 wire coming up through 2 stents that are overlapped at this point and mangled. Here's the coil and the iliac artery, internal iliac artery. You can see that this is quite a challenge to get up through here. And the physician who placed this initial stent wasn't really experienced in stenting. I mean, it was an okay idea at the time because he had done a patch and there was a rethrombosis there. But usually an isolated external iliac stent will thrombose over time, because the path of least resistance for flow is going to be through your cruciate and iliolumbars and around into your hypogastric internal iliac and up to the internal iliac and to the common iliac. So it's going to bypass a stent or a thrombosis at this level. So if you have an external iliac thrombosis, you usually get collateralization across the pelvis, iliolumbar, and actually up and around like this. So if you put an isolated stent here, don't be surprised if you find it just like this guy, totally occluded. So the deal is to get up through this, and here's our sheath. And that's good for me because then I can go to CT and it's radiolucent, and I've taken out all the other catheters, and I can see for sure that I have my sheath in the middle of that stent. And that's important to me to prove that it's there, because I want to use a laser catheter to go up through this really hard, firm stuff that completely fills the inside of that stent. It's more than a rubber eraser. It's very firm, and it's very hard to direct. You can't turn the catheter at all. So the good thing about a laser, it'll just go up slowly but surely and vaporize the material. And hopefully it will not go out through the struts of the stent, and you can make the curve and get up to the cava area. So we've done that on a number of cases. And I know Dr. Raju's worked with laser in this respect too, and it seems to be effective, especially because it will soften up that old organized stuff in the stent and allow you to get a much better result when you angioplasty with your high pressure Alice balloons. So you can see what we started with, and you can see the result. Now he's 2 years out. He comes back from the East Coast once a year for us to look at the stents, and he is on Coumadin. He's fine with that. He has his own monitor. I believe that he would not be able to keep the system open without good anticoagulation. And now his leg is as good as it can be, and is good for the last 2.5 years since he got this opened up. But this is a very difficult case, and it took about 3 days to complete from beginning to end. So you can see his leg is still swollen a little bit, but look at the discoloration is much less. His ankle is much smaller. He's much more active, and it feels a lot better when he walks. Now, just a couple of points as we end here. I want to emphasize to you that these collaterals, which I described, can come and they will keep open your common iliac, and they'll keep open. It'll keep open till these collaterals come off in your iliolumbar and your hypogastric circumflex collaterals. And this is a lady, this is the first lady we ever put wall stents in. You can see how ragged and chronically occluded she was in these areas. And I knew that if I did not stent her across the inguinal ligament into her upper thigh, she would never stay open. It would be absurd to just put a stent to here. And this was early on in the early 90s when we hadn't stented very much yet. And I remember asking Mike Dake over the phone, I said, have you ever done this? And he said, no. And I said, well, I think I better, because otherwise it won't work. I think I have to stent down to her upper thigh. And this is the principle of good inflow and good outflow. You have to stent down to where the inflow is good. And that's usually at the level of the inner trochanter. So I remember exactly what he said. He said, just go for it and see how it works. And she had patent stents until she was an older lady then, but she had good patency in her stents for years. Now, this is a patient that we sat up on the table so that we could get lateral views of what the stents look like when you're sitting, because everybody seems to think that their groin is kinking, so their stents might be kinking at the groin area. And I want to show you the curvature. It's really important. When you come down from the IBC, here the stents, they come down, and the curve is actually right by S1L5. And this is in the common iliac, right before the external iliac starts. So there's a curve at that level, and the stent and the vein are going posterior and then curve up towards the cava. The common femoral vein is not kinked. It's very straight. Here's the femoral head. You can see bilateral femoral heads, and here is a wall stent traversing the femoral head. This is why if you put stents like this to your inner trochanter level down to your proximal femoral, the stents stay open. They don't get kinked. I've only had a couple of patients who were so aggressive with squats and weightlifting that they started to damage their stents. But in general, for normal living, the stents are actually well suited to this area, and they do not kink. So it's important to know that, so that you do extend your stent to the point of good inflow, which is usually the inner trochanter. So remember that crossing a totally occluded iliac vein is like a puzzle. Advancing the wire is like picking a lock. Basically, it takes a combination of this desire to solve the puzzle and patient trying with the wires. I'm not saying it's not tedious. I'm not saying it's sometimes very challenging, but it's also very gratifying when the wire goes where it should and you get up into the IBC. And because of this technique, you can change someone's life long term, because these stents do stay patent. So think about the Italian job, and I encourage you to see it if you haven't, because there's so many similarities of driving a Mini Cooper through a canal and all of these things that remind you of vascular work at some level. So thank you very much for your attention, and I hope that that was helpful for you.